let me introduce myself so that you get some idea about where I'm coming from. I would like to talk about the challenges I have faced during an implant practice, which I think we can all share and agree and get some insights together. For those of you who don't know about me, I graduated from UCLA School of Dentistry in 2003. I practiced as an associate for about 5 years in LA and until I opened my practice in San Diego in 2008. So my clinical experience has been about 16, 17 years and been placing implant for about 10 years. So I like to start about the things that I've heard from my instructors and my mentors, that implant has been around in dentistry for more than 50 years with 98% success rate, and more than 500,000 Americans are getting implants every year. And there's been no better time than now to do implants due to the accumulated knowledge and breakthrough technologies. Yet, less than 50% of general practitioners restore implants and less than 10% actually place implants. And why is that? I think it's due to the uncertainty, unpredictability, and stress from surgery and restoration. And I'd like to deep dive in today to each of the hurdles and go over how the digital implant system helped me and help you to jump the hurdles of each problem. So benefits of digital guide implant system. First is the decreased unpredictability of surgical outcome and increased predictability of surgical outcome as well as restorative outcome, and decreases the stress from prosthetics. And do the implant procedures, if we could do it faster, restore faster, and may be able to increase your productivity and profitability. And by utilizing the digital implant system, you can expand the scope of treatment services that you can provide. You'll be able to do many cases that you would have referred out before, such as immediate implant places, sinus cases, and even full mouth cases. So what does it really mean to have reduced uncertainty? It means less fear from what's coming and the fear of the unknown, such as bleeding, unexpectedly entering sinus, unexpectedly cutting vital structures. She was a 56-year-old school teacher, came in waiting for lower teeth implants on the mandible, and this is the post-op panel. It looked reasonable. Well, there's a reason I'm showing you this, because there was a big mistake or trouble I had with this outcome. Mike Tyson once said, everybody has a plan, but there is unpredictability in when you get punched in the mouth. And things happen. When Emma came back from the surgery, what I got was a paresthesia. She doesn't look too happy, which I find it pretty common if you do a lot of implants. According to some studies in 1990s, 37% of Canadian implant doctors, 36% of Australian doctors confessed they had some type of altered sensation in their career. In the United States, Michigan Implant Institute graduate survey indicated 87% had encountered situation of neurosensory impairment. So if everybody does it, is it okay? No, especially in the very litigious society as in the United States, with all these lawyers looking for dental implant complications. What would be the cost of paresthesia? A well-known oral surgeon, Dr. Resnick, had to pay $400,000 which is $500,000, and red mark on your board record. And to prevent such a complication. Only thing I could do was praying after I see the patient. And we're not talking about faith and praying on this Sunday, but with God's gracious mercy, patient senses came back. So with this type of problems, it made me think, what could have been the cause and why did it happen? First, I may have directly severe intraalveolar nerve or touched the mental nerve. There could have been anterior loop in the mental nerve right before the loop. I may have inflammation or swelling or hematomas compressing on the branch. And when you lay a flap with all those small terminal branches of mental nerve spreading, I may have severed the portion of the nerve during the incision or flap reflection. So how do you fix it? A better question is, how do you prevent it? Now I'd like to share a situation where I had a patient who needed implants of the lower mandible as well, but with a different method using a digital DIOnavi. This is how the workflow goes. So let's dive deep into the other patient we were placing implant on 19 and number 20. This is how the surgical planning would be done in a 3Shapes implant studio. We're trying to make sure the path and axis of implant plate fixture would be safely away from the vital structures. At the same time, have a good orientation to the opposing dentition to have a good axial loading. And due to the flatness nature of a DIOnavi surgery, we wouldn't have to worry about laying a flap or cutting the anterior loops of the mental nerve. So this is initial, but after the post-op, work is done. What's good about this digital implant surgery is you can have complete trust on the system. You can pound, press hard, sleep, but will be guided, fully guided without your hand sleeping, and you know you'll be in the safe zone. Second thing I'd like to mention is about increased predictability of your restoration. We always want to be able to consistently deliver what's been promised to the patient and fulfill the commitment. Inconsistent results, unpredictability are going to hurt your business, hurt your career, hurt your reputation, and you cannot afford to have 3 to 5% of failure, which is normal in the literature of implant failures. And you don't want to have that legacy of failure, whether it be surgical, prosthetic, or aesthetic. Why not 100%? So this is sharing of another mistake. This patient came in for implants on number 18 and number 31. This would be the outcome. It's not the best outcome that I like to share proudly. I ended up with a big cantilever crown that looks like upside down golf club. So this would be a prosthetic failure, and I didn't even recognize it until I started to restore the crowns. And again, let's think about why. Why did I end up like this? First of all, you have a very small working area, especially if you're working on the very distal ends of a patient's mouth, and a very small working area and a small field of view. And the view is obstructed and give you an optical illusion of where your drill is versus real place. There's something called Murphy's Law. When it rains and you took out the umbrella and the umbrella is broken. And the Murphy's Law on dental implant is that 100% of badly placed implants integrate really well, and you're stuck with it. So let's find a better solution, which will be utilizing DIO's digital guide implant system to illuminate the blind spot. Let's take a look. Using the computer's virtual planning and design process, you can look 360 degrees around the patient's mouth. You can look into the patient's mouth from the back of his head, and you can also look into where the functional cusp would be lining with the opposing dentition and the depth related to cervical emergence profile. So this would be a planning of a surgical guide without engaging the undercut. So that the surgical guide would be seated passively on the patient's mouth. Once you know the hard tissue and soft tissue have merged and showing up green in the implant studio, you know you're going to have a very good, accurate surgical guide. And the accuracy of 0.03 millimeter. You can see it on the screen. Then you will be able to have the most accurate surgical guide to place on the very difficult to visualize area. And with given DICOM and STL file, even custom abutments and final prosthesis will be ready before the surgery. So this will be the patient's actual information in the beginning and comparing that to the final outcome. And since all the hallmarks and consideration is done before the surgery itself is quite fast and undramatic, however, very predictable and easy. CT comparison of the pre-plan and post-op to the pre-planning. And I'll be much happier with result compared to the surgeries I've been doing before. So this is a commonly asked question. If I've been doing implants for a long time and I don't need surgical guide, I have placed 10,000 implants already. And the question I like to ask back is, how many of those 100,000s are in the best position, path, and depth, and best final restoration without complication? I am a type of person who like to wear belts with suspenders. I want 99% success rather than 95%. We want to achieve 100% because if 1 out of the 20 implants fail, you cannot afford to have a good legacy in your community. And I do want to make sure another point that what you are getting is not just a surgical guide. In fact, it's a prosthetic guide, which allows you to design virtual tooth with the best tooth embrasure space and height of contour and the inclines of the cusp. So for instance, if somebody came in like this, asking for you to get a tooth number 9 with an implant, how would you treatment plan this? Where should you place the implant? Do we just place implant where the bone is? Or do we just eyeball it? Here's this planning, looking at all the different aspects of the tooth number 9 and pre-made implant restoration. And we'll be able to make it implant look like a teeth. Now we're getting to the third point, benefits of digital implants. Decreased stress, reduction of stress over surgery and restorations. Operator says, relax, David, it's just a small surgery and don't panic. Patient says, my name is not David. Oh no. I mean, I know that I am David. I'd like to share some stress situations. This patient came in as an emergency, 50-year-old female with broken tooth number 9 down to the root, and the tooth will have to be taken out. If you're planning to, if the patient is demanding that she would like to have an implant, what are some criteria that you need to think before or during the surgery? A lot of things. You would have to match the CJ of adjacent tooth to be at the same as the platform. And that platform needs to be 3 millimeters below facial free gingival margin and at least 3 millimeters medial-distally for proper emergence profile, and to have 1 or 2 millimeter buccal plate, and try to position palatally if you want to restore screw retained. All those things need to be considered while you're laying a flap and the patient is bleeding, gagging. And can you do it? Of course, if you're an experienced, seasoned doctor. But is it easy? And is it stressful? That's sure it does. And to do it right is even more. So here's a failure that I'm showing. I'm embarrassed to show. What went wrong here is the fixture moved to the side of least resistance, which will be the buccal plate. Why did this happen? We were told and taught to drill palatally as possible and not letting the fixture slip into the extraction socket. But as you're drilling, the fixture starts to move where the least resistance is. And even though you drilled it well, as the implant is drilling apically, the implant fixture tend to move to the buccal. What we knew and learned, but sometimes it doesn't happen, and I slipped. So the patient came back with this disastrous look. Patient came back asking, where is my implant? Is it into my nose? Well, Mrs. Smith, don't worry, it will grow. And I don't know what I said to the patient. But then that night, I'm going to have a sleepless night with a lot of prayer to do. And praying is not enough here in a situation like this. You need a push. Push is pray until something happens. So this is how it's been fixed. The pictures show a lot of stories, but to boil it down, I had to use angle custom abutments and months of growing gingival tissue and extra semilunar coronal advancement surgery and connective tissue augmentation. The bottom line is bad placement in surgery leads to a lot of unnecessary stress and a lot of unnecessary treatment time. So there are times, even if you try your best and prayer doesn't answer, sooner or later, you will realize that I need to take a leap from flaws to perfection, from stress to ease and happiness. I need to take a leap of faith to do it right. Would be to adopting digital technology. So I'd like to share another case that is pretty similar to number 9. Imagine this patient sitting in front of you and considering all this CEJ, bone volume, buccal lingual, mesiodistal. Would you be stressed as much as before? Not really, while still considering all the factors, the angulation, position, and depth. But I'm not stressed during the surgery because all the homeworks will be done before the surgery. And surgery will be much more quicker and faster. Patient has been digitally scanned and a CT is taken, computer planning with merging. And here's what the patient's treatment planning looks like with surgical guide. And all the consideration that I wasn't able to think about during the surgery, such as the shape of concavity on the emergence profile and the abutment, and the angulation that will allow me a screw retained crown has been also taken care of before the surgery. This will be a post-op cone beam CT analysis of the result. While working on his case, you could imagine how much stress, how much less stress would it be to do something like this. And I'd like to share some video of anterior implant surgical placement. A few things that I'd like to mention about this surgery is that the surgery and the restoration is pretty quick. It takes about 50 minutes from surgery to getting the restoration. And another thing is, as you can see, the doctor and the assistant don't look too stressed because they all have a roadmap drawn up for them, and they know what's coming ahead, what drill goes next. There's no improvisation, no bleeding control, but just clear path. And let's skip the patient's response. Another frequently asked question. Your system will work if patient has a good bone and good attached tissue. Yes, it is true, but it will be easier even if the criteria are not met. Or patient needs a bone graft, free gingival graft, or apical repositioning. But sometimes you will be able to bypass in certain situations with the accuracy of surgical guide where patient doesn't have enough bone. Here's a young girl ready to go to college. Mom brought her in and her chief complaint was that she's not able to smile. She doesn't smile because she has congenitally missing lateral for all her teen years, and her mom is concerned that she will not able to find a boyfriend when she go to college, and she will not get married, and her life will be miserable. She's got to get back to a good, beautiful smile. And Dr. Kim, as my general dentist, what can you do for her? And this is the bone she had. When she got a consultation from periodontist, she was recommended to get block bone graft from her jawbone, possibly additional gum graft cut off from her palate, and it's going to cost tens and thousands of dollars and multiple surgeries. And what do you think? Well, I'm just your general dentist, but let me see what I can do. This is Kim. I would like to be able to help your daughter, and I showed her our treatment plan. If I can place implant accurately and bisect the bone, she may not need to get additional bone graft. And if I can place in a very good depth, she may not need a tissue graft and not go through multiple surgeries and sedations. And the table has turned around, and her mom was begging me to try this digital implant.
Hey, get on with it!
I bet he wishes he was tossing cabers.
Or holding up bridges. At least you!
Merida, I forbid it.
How is that possible? Because DIOnavi has the world record of an accuracy, according to the study, with a less than 0.026 degree of inaccuracy. So this is how the girl looked before and after. And the young lady finally smiled for us for a picture. Now, on certain situations, digital guidance implant system has bailed me out from the difficult situation. But what if patient really needs a GBR? Patient does not have enough bone. So this is another tip number 7, lacking a horizontal bone volume. If you've been placing implant, this would be a typical route you would take. You open a flap, confirm the bone defect. Now the bone defect is down to 9 millimeter apically, and you can imagine how difficult it would be for you to drill implant freehand. Now let's consider this situation now with the guide in. How difficult is it to have implant placed on a perfect angulation, even though there's a bone defect? Not too bad, because there's going to be a physical guidance of your drills and the handpiece from the surgical guide. And after the implant is in a perfect position, you just go ahead with your procedures that will be needed next. GBR, membrane, suturing. Then you still have minimize some stress and still be able to achieve a good clinical result. This will be a PA after the suture and appreciate what you see that the implant is still fixated with a good stability. What if patient needs soft tissue? The subperiosteal tunneling approach is the minimally invasive procedure that allows surgeons to allocate the graft in a space between soft tissue and the underlying bone through an axis represented by a single incision on a mesial limit of a bony defect. Here's a situation utilizing DIOnavi, which require tunneling graft. And there are reasons why you would do tunneling compared to the traditional GVR or rigid split, but we'll go on. Here's the pre-op CT and scan of patient who definitely need or definitely lacks horizontal bone volume. And one of the reasons for tunneling would be to preserve papilla structure as much as possible and prevent interdental bone loss from a flap that is bound to be decreased once you cut the periosteum and introduce them to the lack of blood supply. So here's how you do it. Now, another difficult situation and frequently asked question, your surgical guide system may not work in all the time. Here's one creative application that you can use. What if patient does not have enough keratinized tissue? So mucogingival junction is right at the center of ideal fixture position. Here's the shortcut I took, is to make very small micro incision to reposition the flap and introduce a surgical guide and place an implant at the ideal position. And this has been all thought out before and not guessed during the surgery. Now you want to lower that apical tissue to have a keratinized, at least 2 millimeters of keratinized tissue around the implant. And this would be the final outcomes. Now let's talk about another benefit of impact is to expand your treatment scope. The more you can do, especially good for at this times like this, where you don't have to be referring out the cases out to the other specialist. Emergency treatment. What if you want to do extraction and immediate placement? Will you be able to use surgical guide? Yes, and it will be very useful tremendously. This patient is 21-year-old female and number 8 and 9 avulsed from hitting a tennis racket. And the challenges are that you want to preserve papilla because she is very aesthetic demanding, and you want the gum line to be aesthetic. And as you can see, she's got a thin biotype. And last thing is she had a very high profile lawyer and dentist in her family. So she's been consulting with her aunt, a dentist in San Francisco, and she was asking me, she would like to have her nephew have extraction and immediate implant placement. Easy to be said than to be done, but how we're analyzing our situation. How far should we go down? How far should those two implants be? What should be the angulation? So this is a treatment plan and a perfect consent to the patient and to her aunt as well, with the picture and software. And you're going above and beyond of a standard of care that you're using cone beam CT scanning, and you put efforts to do the planning and using a surgical appliance and promise that this is what we intend to do and this is what could be done. So her dentist in the family agreed on immediate extraction and implant placement. If it was a free hand, it would have been a lot of stress for me. But with the digital planning and surgical guide and a pre-made prosthesis, I could promise that I could at least deliver fixture at the right position and avoiding something like this. Imagine having a fixture that's with small angular deviation like that on number 8 and 9. It would be a disaster to restore. This is a preparation for her immediate extraction and bone graft. I used a mixture of allograft and xenograft and membrane. And to make sure that I wanted her fixture to finally end up really well, I took a CBCT with the surgical guide on a patient and evaluate proximity to the CJ of adjacent teeth and not to penetrate her incisive canal and not too high to avoid remaining buccal plate, and root inclination to engage the palatal bone, and to make sure that the dead space or jumping distance is not too great. This is right after the immediate traumatic extraction and implant placed and allograft. You see, there's no incision, flap, and bleeding. And you may wonder how the allograft got placed. And this is how the bone graft will be placed. After the fixture has been placed, put a cover screw of Hicks or healing abutment and pack the graft material into the bone or to the dead space, and you can put temporary restoration. So this is right after the surgery. There's no flap, no sutures, pre-made temporary already placed onto the patient, and patient will walk out like that with the teeth. And 2 weeks of tissue healing, 1 month, the tissue looks much more mature. And in about 4 months, the bone has shown a good osseointegration, and we were able to restore in about 4 months. This would be before and after. And CT analysis. Now, another thing that we can do with the help of a digital guide is a socket show technique. Let's talk about a socket show technique. Is to decrease uncertainty of a soft tissue and increase the predictability of restoration. Because we have challenges in the aesthetic zone that we face in the long term with anterior implants. What are those? Will the papilla stay after implants stay there for a long time? And will the gingiva recede? And how long will the buccal bone last? So the bottom line of these are the challenges of an aesthetic implant on the aesthetic zone, where there's a collapse of a buccal tissue, gingival receding, and loss of papilla. Traditional method would be to go through GBR with soft epithelial connective tissue graft, but there are a lot of advantages on the socket tissue route because preservation is a lot more predictable and long-lasting compared to regenerating when you have lost those papilla and the bone. So socket shield is a partial extraction therapy by cutting out a part of the root and use that buccal part of the root as a shield to prevent the buccal bone collapsing, because the buccal remain of the root will have a PDL that is still supplying the blood supply to the buccal area and prevent the collapse of the buccal plate. Easy to be said, but it's very technique sensitive because it requires a lot of ideal dimensions. It requires the depth and the distance from shield, and it's very tedious and technique sensitive. But again, let's see what digital DIOnavi guide can help in calculating and the measurements before the surgery. So first of all, you cut the root and extract it out. And I remove the palatal portion and do a guided surgery and implant placement. The goal was to leave 2 millimeters of buccal bone, including the socket, the shield. Look at the outcome. There's no, we have just enough of the root structure and the graft material between the socket buccal root and the implant fixture. What does it achieve? It's clinically very powerful to maintain the volume on the labial crest ridge by preserving the labial bone plate. As you can see here. Now, another procedure that may add on using a digital implant system is a maxillary sinus lift. We know it's a prevalent, a lot of people lose maxillary posterior teeth and the sinus collapses, and restoring a vertical deficiency is quite challenging, but it's very prevalent that you need to master. And what are some previous traditional techniques to achieve the sinus lift? The first one was lateral window technique introduced in 1974 by Dr. Tatum. Here we need to lay a big flap to access and drill out the lateral wall. I would say this is a very predictable technique, but there are a lot of downside to it, which are complications. Complications including the problematic bleeding and patient having edema or bruising and perforation of Schneiderian membrane, which account for about 15 to 30% in the old technique using a high-speed rotary. And even with the piezo unit is still 5 to 7% of perforation. And when that window fails, the complication is quite morbid. And sometimes you wouldn't want to handle this because there's sometimes implant may end up in the sinus and infection in the implant sinus site and a delayed surgery.
Tapping to a little bit more, and this is the procedure where we're actually going to do a mini, so lift up the bone itself. So you hear kind of a little pop, and this little pop will allow you to know that you're actually through.
Well, I wanted to talk about osteotome technique, but osteotome technique introduced it about around 1990s to make a micro green stick fracture and introduce a bone graft material from the crestal side. But the limitations of this technique that it needs a good amount of a residual bone, and that is a blind technique. Therefore, we don't know the status of the Schneiderian membrane, even though we introduce the graft material. It's uncontrolled, and patients may experience paroxysmal vertigo from malady and discomfort from the flap incisions. And people were trying to figure out much less invasive alternative to lateral window or osteotome technique. And fast forward 10 years, we have a lot of crestal approach techniques. Common themes of a crestal approach that are that you want to control the osteotomy and safe detachment of membrane. However, all this crestal approach technique lack in issues with these complications. You still have to lay a flap, which increases unexpected gingival recession. And when we have patient has a very low alveolar crest bone height, and that we're introducing 1 to 1.5 millimeter of bone resorption as expected, and there's no confirmation of the status of membrane, state of the membrane. And because it's on a very difficult visualization area, osteotomies can lead into very unfavorable position for restoration, such as this. Now I'd like to introduce a new technique where you can place implant in an exact position and depth and have a better tissue healing because there's no flap, and decreases healing time, decreases surgery time, and less post-op discomfort. And yet still achieve accurate and predictable results. And be able to access the sinus floor very safely. And utilize CAD/CAM to deliver immediate or accurate deliver prosthesis. This will be a flapless crestal sinus lift using a DIOnavi system, where we measure the depth or length from surgical guide to the sinus floor, and the length from gingival crest to the sinus floor. And with this information, you can drill only down to the bottom of the sinus floor. And once you reach the sinus floor, you introduce hydraulic pressure or saline into the floor to detach the Schneiderian membrane. Even if you perforate or the water gets into the sinus, it will be very, very safe and not cause a lot of a complication. Okay, from my personal experience, there is no limitation. Sometimes you would just introduce a graft material into the sinus floor, and you could revisit the implant placement. The biggest limiting factor is the stability of a fixture. If you can engage with just 2 or 3 millimeters of the cortical bone at the floor of the sinus, if you could engage, then you can introduce an implant. So I'd like to share one of the cases where I had a very, very thin ridge remaining. And can you see the screen?
Yes.
Okay. So this patient needed implant on tooth number 14 and 15. The sinus cavity downward growth has expanded for a long time, with the residual remaining bone about 2 to 3 millimeters. And we want to put at least 8.5 millimeter lengthening of implant there. So looking at the analysis, we decided we'll need at least 7 to 8 millimeters of sinus lift. This is using a hydraulic pressure to lift up the Schneider membrane and introduce the bone graft. And this is the outcome of measurement about 7 millimeters of a lift on number 14 and about 8 to 9 millimeters on number 15 area. So to answer the question, my answer would be, if you have a good cortical bone to engage to provide a stability of a fixture, you can do it even on a very thin ridge. Now let's get more creative. What if you still don't want to avoid the sinus lift? Okay, and using a digital implant system, what are some of the options? Let's look at this patient. Patient needs tooth number 13 and 14 implant. And patient doesn't really want to pay for the lift, and also does not want to go through multiple surgeries. So we planned it out to diverge out the implant fixtures. And maybe we can, if we could place accurately, we'll be able to avoid lifting the sinus. And this is the outcome. As you can see, because we were able to achieve the pre-planned actual result, like a pre-planned, she didn't have to go through sinus lift surgery and has to have the restoration. This is another situation with patient asking or needing tooth number 15 implant, very far distal. And this is pre-op. You think patient would need sinus lift there? I would have thought so. And if you look closely, this patient actually did not have a sinus lift, because we were able to determine from the CBCT that patients, if we could incline the angle of a fixture, we could have it without lifting a sinus lift and still achieve reasonable axial inclination to the lower opposing tooth. So looking at the final placement of an implant and to the final restoration. Patient was very happy that she didn't have to go through sinus lift surgeries. Now let's look into more exciting stuff to doing a full edentulous cases. What are some of the advantages? If you do multiple implants, it gives you a chance to immediately load. And also it reduces your surgery time significantly. And there are a lot of people, approximately 30 million, fully edentulous arches, and it's growing. So this will be a most typical type of full arch cases that will come into your practice. Patient is not completely edentulous on the mandible, but will come with the terminal dentition, because we were trying to have the patient hang on to those teeth with the bridges, fillings, and a partial denture. But eventually time comes when it would not be possible to just hang on to the partial denture. Now, when we think about an edentulous arch, here are the options we have for the patients. A complete denture is much less expensive, but have issues with stability, retention, and function. Maybe if you just throw in 1 or 2 implants and produce an overdenture, patient satisfaction will be greatly improved. However, there are potential for rocking in AP direction, reduce stability and function down the road. So we can throw in few more implants, and bar can be placed, either be fixed or removable, but the cost is going up and up. If patient has no financial issues, we can place 6 or 8 or 10 implants, but this will require a patient's commitment in financially as well as additional surgeries such as sinus lift or ridge splitting, ridge grafting, which can also add to the morbidity and treatment time. Alternative solution we have for patient is to do all on X, where it's still fixed and we bypass the need for the grafting and patient can have immediate function. But the downside is we were taught, if you went to dental school a long time ago, it was contrary to what we had learned in dental school, that it would have an unfavorable biomechanical load. This all-on-4 method had been advocated by Dr. Polamalu, trademarked by Nova Biocare. And the biggest challenge was that the biomechanical unfavorability, but evidences and journals start to show high likelihood of success on all-on-4, all-on-X implants starting 2003. First in mandible, and then 10 years follow up with good results, even on maxilla. So now it has become more widely accepted by dental professionals. All-on-4, all-on-X concept is grabless approach with maximizing the available bone. 2 or more on the axial implants with 2 tilted implants. Provide excellent primary stability by maximizing bone to implant contact and maximizing the AP spread and minimize cantilever length, and reduce the need for the bone grafting. As you can see, traditional all-on-neck surgery versus digital guided all-on-neck surgery. Unless you have a digital analysis and a surgical guide, you have to lay a full arch flap and implant placement on fly, which can possibly exceed or short of an ideal position and depth, hit sinus or mental nerve, and because of a big size of a flap, bleeding control, suture, and verification angle be our own issue, and the time would be the most downside of doing an all-on-X without a digital planning and a surgical guides. And once the implants are placed, even the restoration phase is very complex and time-consuming. Traditionally, conversion is required. You have to buy titanium chimney, tedious work to prevent PVS trap into tissue, trimming, placing a rubber dam and all that. But digital work process can eliminate many of these steps. This will be a simplified DIOnavi full arch process where guide is made, implant placed, and have a provisional ready to be delivered to the patient on the day of a surgery. And I'd like to share a real patient situation. My patient's name is William. He came in for implants because he was very satisfied with the lower overdenture. Now, issues with him is over the years, patient has developed hypertension and diabetes and is very different. And looking at the sinus and amount of remaining bone will have to be require big graft surgeries bilaterally. We gave William an option.
My father had full dentures on top, and as he got older, they didn't hold in, and so I wanted something.
amazing thing about all-on-4 or all-on-6 implant is that patient actually doesn't have to go through extensive bone graft surgeries and just use the available bone. What are you looking forward to with the new teeth? Looking younger.
That's right. Yeah, and having the probably go to Poland and Austria.
Okay.
With June.
So this will be William and Philip transitioning from terminal dentition to just 4 implants. And a temporary immediate loading of PMMA. And then once the osseointegration has been done, final prosthesis delivered.
Right, can you tap tap?
So to these patients, this is a radical change for them to be able to chew and function back to the way they were before. You can see the gleaming in their eyes and making a change in their lives. So we're getting almost to the end. One of the biggest benefits to the implant surgeon is that it's going to reduce surgery time and decrease your treatment time, where time is money and productivity. Okay, again, I'd like to emphasize that the surgery actually took less than 10 minutes. And if you think about it, I don't know how many procedures in the dental offices can take less than 10 minutes and still have high productivity as an implant. Now, I want to show about, can we reduce the time for loading? So I'd like to mention about the photo functionalization effect of an implant, which leads to much faster osseointegrations. Let me get to the point. Since we're running out of time, the bottom line is, in a typical osseointegration process, patient is going to lose mechanical initial stability while biological stability, which is osseointegration, is taking place. It deeps down till 6 weeks. And if you could attract the blood supply as much as possible from the beginning, you could reduce that danger time where there's a dip of a stability and start the osseointegration faster, and you can load faster than usual. As we're reading to the conclusion part, I want to share what impact I had to the patient utilizing the digital implants. Patients were mentioning that they were very satisfied with the implant they got, and no other dentist told them about this kind of method and benefits, because there weren't too many dentists doing computer or digital guided implant surgery before. And they wish they had gotten implant this way, because their previous experience with implants differs so much from what they experience now. So why do the patients say some things like this? Because patients are afraid of surgeries. Patients hate going to dentists for multiple times to have inaccurate results. And they're very busy with their own life. But imagine being able to deliver a faster, accurate result with much less complications, where there's no water, no heat, and no noise during the surgery. So with the digital implant surgeries, you're gonna have a much less surgery time. On a patient perspective, it's much less mouth opening, and be able to have immediate loading in certain situations. And the golden questions to ask yourself, if you're listening now, that if you need a dental implant, what surgery method would you choose? There's a phrase that treat others like how you like to be treated. And at the end, we have to mention about what are the limitations of adopting a digital implant system. Well, first, there's going to be some learning curve, and doctor must understand all the variabilities. And you cannot do it alone. You need a support from the implant company, support from the peers, support from the mentors, and networks.
All right, let's take a look at that cavity. Say ah.
Welcome to your Dentistry diagnosis app.
I made this app myself. I'm a bit of a tinkerer.
Can't see.
Good enough.
So my cavity is actually just in the
Nope.
back.
Don't worry about it. I've got it. Open wide.
Counting 32 teeth. 1 filling.
It's impressive, isn't it?
I have 2 fillings, not 1.
Oh, it's close enough.
89 teeth. 115 teeth. Hexagon. Mouth-shaped breath.
I downloaded that patch. Let's see.
The bottom line is that you cannot rely the technology 100%. You still have to be the doctor to control and be able to manage potential areas of error to have a good positive outcomes. So I think digital guide system is not the solution, but it is a super tool you can utilize. But for you to maximize its use, you need to take it to a straight road first, and then learn how the car moves and learn to all the mechanics of it. And then you can take it to the curvy road. Maybe you can compare it to like a narrow case or case that needs some graft. And then you can take to the dangerous road where you need to be involved sinus lift and full mouth cases. When you have mastered those roads, then you can be more creative in how you drive. However, we were nearly aware that you still have to continue to learn, and there are a lot of courses, seminars out there for you to master, and you have to be connected to the like-minded dentists, like-minded people to up your skill. And I think DIO has really stood up to provide those opportunities. And I think the DIO is also planning to do a continued webinars possibility in the topic of a full arch solution and best practice for digital implant checklist. Those type of seminars and webinars could help hone your skills. And before we end the webinar today, I'd like to ask you, remember the time when you were driving with the map, and now the map is archaic. We stopped using it. And it's been only 10 years that people adopted navigation. It doesn't look too far long ago, but everyone took a leap of faith, and everybody took a step forward to make that change. In a way, digital implant system is like driving on a driverless car. It will take you to places from point A to point B to your final restoration, final destination. But in a way, you're blinded, and sometimes you doubt the result. But you have to overcome the status quo and scary feeling of that change. Like this mom was going through a scary moment of being...
A terrified woman freaks out behind the wheel of a car driving itself. Oh, dear Jesus.
So believe in yourself. Don't ever let anyone tell you that general dentists can reach the highest level of success. A lot of times we limit ourselves that I cannot do the surgery. I cannot do as well as so-and-so. My practice cannot grow. How can I do this type of surgery? A lot of times we limit ourselves. Maybe not now, but maybe with the help of technology and a support team. You have to go beyond limiting beliefs to believe that you can be a great implant surgeon, even as a GP. If you want to be, you can dream to be the best implant dentist in the town or city. Of course you can. And go beyond your limiting beliefs and don't limit yourself. And I thank you so much for this time. And we'll have a Q&A answer. I'll try to answer as much as I can. Don't stop learning. Hope this webinar was helpful, and take care. And I'd like to take mic over to Stephen.
Yeah, thank you, Dr. Kim. I know we started a little bit later than our usual time. Would you be able to take one or two more questions before we end the lecture?
Yes, I waiting to answer any questions.
Okay. Some of the questions I got amongst them, I want to address this one. How do you communicate planning to DIO designer? Would you answer that question for us?
Yes. So is everybody seeing me on my screen? Okay, so to answer that question, DIO designers are like lab technician or lab master technicians. So they are very familiar and experienced with doing many cases. However, as a doctor, you need to decide what are the criteria that you want to have, such as how deep your implant to be, how the embrasure, what kind of embrasure space you want it to be, and I can show you what I gave to my lab technician. If you are seeing my screen, this is one of the requests I gave to my lab technician or the DIO designer to have interproximal contact be less than 5 millimeters on crest of bone. So this distance from crest of bone to the contact to be less than 5 so that the papilla would not reduce. Another criteria that I give to the designer is to have a free gingiva top. Distance from implant fulcrum to the free gingiva more than 3 millimeter, but less than 5 millimeter, which is to prevent alveolar bone loss. Distance between implants, I'm pretty sure a lot of doctors already know, but you want it to be more than 3 millimeters. And why? Because you need the blood supply for the alveolar bone not to collapse. Buccal bone thickness, at least 1.5 millimeter in the research and in the literature. But if you do a flapless technique using a DIOnavi, it could be little more lenient because you're not going to cut away the blood supply from the periosteum. I'll be happy with just 1 millimeter of buccal bone thickness. So things like this, these are the type of things that I communicate to the DIOnavi designer so that the most ideal outcome as I want it to be customized.
Yes, thank you. Maybe we have one more question to take before we end. Would you answer one more question, doctor?
Yes, I'm ready.
Okay.
I'm here. All yours.
One other doctor asked, what if patient has limited mouth opening?
One of the biggest challenge of a digital implants are, if you're using a guide system, the drills are much longer than traditional implant drills. And there are few tricks that you can use. One is to have a drill fitted into the guide and put it into the patient. That's one. And the other option is in the DIO system, there's a very, very short length drills, even at 2 millimeter. If you put that short drills and do the first osteotomy, and then you can subsequently increase the length little by little, going to 3, then to 5, and to 7, and to the final length, you will still be able to achieve desired osteotomy depth, even with the limited mouth opening.
Okay, thank you, Dr. Kim. So I believe we have answered pretty much all the questions that has been asked. Yes.
No more.
Yes. So I would like to close by thanking everyone once again. I appreciate your attendance. It was a pleasure having you to be a part of today's event, and I hope that you feel confident to move forward to the next level and take on more challenging cases after this webinar.